Diabetes in Underserved Communities. This is a DNP-guided secondary prevention program that's aimed to assist diabetic persons with health disparities. This program will focus on social determinants such as socioeconomic status. There are two tables of contents. Objectives included will be defining and examining diabetes and the impact of diabetes in underserved communities. I will also propose an interdisciplinary plan to address the needs of these patients. I will define the 3 levels of prevention, focusing on the secondary prevention. DNP leadership and skills will be addressed as well as the interdisciplinary team that will be involved. Diabetes is a chronic disease that occurs when the pancreas is no longer able to make insulin. This is type 1 diabetes. Or when the body cannot make good use of the insulin that it does produce. This is type 2 diabetes. The numbers associated with diabetes is astounding. These numbers are particularly alarming when one considers that among the nearly 500 million people with diabetes globally, 3 out of every 4 persons with diabetes live in low and middle income countries. According to the Centers for Disease Control and Prevention, these are risk factors associated with diabetes. Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Decades of research have demonstrated that diabetes affects racial and ethnic minority and low-income adult populations in the U.S. disproportionately, with relatively intractable patterns seen in these populations' higher risk of diabetes and rates of diabetes complications and mortality. Socioeconomic status is a multidimensional construct that includes educational, economic, and occupational status. Socioeconomic status is linked to virtually all of the established social determinants of health. It is also associated with the extent to which individuals and communities can access material resources, including healthcare, housing, transportation, and nutritious food, and social resources such as political power, social engagement, and control. It has long been recognized that health is strongly influenced by social determinants. These conditions in which people are born, grow, live, work, their age, including the health system. In fact, the concept of the social determinants of health was woven into the very foundations of modern public health, which at the turn of the 19th century inspired pioneers such as Rudolf Virchow to posit that social medicine was inextricably intertwined with the politics of social justice. Further evidence of the strong linkage between the social determinants and their impact on disease emerged throughout the 20th century, and in 2008 culminated in the report of the World Health Organization's Commission on the Social Determinants of Health, which called for a global movement to recognize their importance in the lacking of health inequalities, with the goal of closing the health gap within a generation. Yet more than a decade since that call for action was put forth, the COVID-19 crisis has abruptly highlighted the lack of progress achieved in tackling inequalities, making visible the linkages and the gross weaknesses of living conditions, health and well-being, and the impact on multiple facets of long-term chronic conditions. There are social determinants of health evidence supporting associations of social, economic status, neighborhood and physical environment, food environment, health care, and social context with diabetes-related outcomes. Inequities in living and working conditions and the environment in which people reside have a direct impact on biological and behavioral outcomes associated with diabetes prevention and control. Life course exposure based on the length of time one spends living in resource-deprived environments, defined by poverty, lack of quality education, or lack of health care, significantly impacts disparities in diabetes risk, diagnosis, and outcomes. There are 3 levels of prevention. This presentation will focus on secondary prevention and ways to treat diabetes through formal education. Examples of primary prevention is maintaining a healthy weight and avoiding smoking. Examples of tertiary prevention is when a person with diabetes is screened for diabetic retinopathy, nephropathy, and cardiovascular disease. Why did I choose the secondary prevention interdisciplinary plan? The need for diabetes education is so vital that the Office of Disease Prevention and Health Promotion created a Healthy People 2030 objective that's known as increase the proportion of people with diabetes who receive formal diabetes education. As an ICU nurse in a low-income area, I have lost count of the number of patients admitted to my unit with uncontrolled diabetes who also have long-term irreversible comorbidities. Over the years, I have learned that noncompliance is not always intentional. Most of my patients have received little to no diabetes education. More than 55% of adults diagnosed with diabetes have never received formal diabetes education. This number is drastically increased for persons who suffer from health disparities mentioned in this presentation. The 2 DNP competencies this presentation will focus on are leadership and skills. In order for any program such as this one to be successful, the DNP must possess leadership qualities as shown here. And although EBP is often viewed as a standalone competency, leadership and EBP are strongly connected. Skills that a DNP exhibits are integrating care, advocating for clients' interests, applying evidence-based practice, research, and standards of practice, and using critical thinking. The interdisciplinary team will consist of these essential professionals. The prevention plan would be successful in a family clinic or primary clinic with a primary care physician. This would make follow-up visits easier and overseeing of the patient's care more accessible. Examples of other programs would be the CDC-led National Diabetes Prevention Program, which is called the National DPP. It's a partnership of public and private organizations working together to deliver an affordable, evidence-based lifestyle change program to help people with prediabetes prevent or delay type 2 diabetes. However, some racial and ethnic minority groups are enrolling in the program at lower rates than other groups. To help increase access, CDC recently funded 10 national organizations to start new in-person programs in underserved areas, which are regions with fewer resources to address health disparities. In addition to in-person delivery, the program can also be delivered online by distance learning and through a combination of these formats. Working with a trained lifestyle coach, program participants learn to make better food choices, be physically active, find ways to cope with problems and stress. These lifestyle changes can cut their risk of developing type 2 diabetes by as much as 58%, 71% for those over 60. Diabetes Self-Management Education, DSME. A primary issue with the prevalence of diabetes in this community due to their socioeconomic status is individuals having insufficient knowledge about their disease and rudimentary competency in managing their disease. DSME is the process of imparting the knowledge and teaching the skills necessary to give people the ability to manage their diabetes. Effective diabetes self-management is essential to achieving optimal glycemic control and decreasing the morbidity and mortality associated with diabetes. The American Diabetes Association, ADA, suggests managing diabetes by maintaining a healthy diet, scheduling regular physician visits, and staying physically active. Blood glucose monitoring is necessary to control diabetes. DSME has also been shown to improve preventative care practices and clinical outcomes, reduce diabetes and associated costs, mitigate future complications, and improve overall health. Regular physical activity, when combined with a healthy diet and medications, is an important part of managing diabetes or dealing with prediabetes. Being physically active can be fun. You can connect with friends or loved ones while enjoying the weather. This benefits everyone involved. Having a partner also helps you stick with the program. The American Diabetes Association has implemented the diabetes plate method. I will be attaching links for this resource and others at the end of the presentation. This is a proposed diabetes care schedule from the CDC. Without diabetes education, patients do not realize they need to continue their diabetic routine, such as checking their blood sugar and taking their medication and insulin when they are sick. With the right tools and support, you can prevent long-term complications such as heart disease, chronic kidney disease, nerve damage, vision loss, and hearing loss. Oral health and foot health are also significant factors that need to be addressed with routine physician visits. The aim of my proposed secondary prevention plan is Start Right to Live Right. If patients are educated from the start, given resource information, and receive routine visits either in person, via phone, online, or a combination of all, along with the interdisciplinary team, the risk for long-term complications are reduced drastically. This is a list of resources for diabetics. Ways to evaluate the outcome are with pre-questionnaires that will be given when a patient is first diagnosed with diabetes. Patient will then receive separate questionnaires that will be completed 6 months following diagnosis and then yearly after that. Diabetes Self-Management Questionnaire, DSMQ. A relatively new psychometric tool to assess diabetes self-management is the Diabetes Self-Management Questionnaire, which was introduced in 2013. The DSMQ addresses dietary control, medication adherence, blood glucose monitoring, physical activity, and physician contact. The DSMQ consists of 16 items covering 5 different aspects of diabetes self-management. All items are formulated as behavioral descriptions from the person's point of view. Respondents rate the extent to which each description applies to them on a 4-point Likert scale. 3 as applies to me very much, or 0, which does not apply to me at all, which refers to the previous 8 weeks. In summary, not all non-compliant patients are at fault. When a patient is not offered diabetes education, the physician, the DNP, and the nurse are the ones who are at fault. We can help improve the health outcomes of people with diabetes through formal diabetes education. Thank you for taking the time to listen to my proposed secondary prevention interdisciplinary plan. Start right to live right.